Thank you for joining in. Today we are discussing shoulder overhead mobility in athletes. But of course, we can extrapolate all discussion to even a non-athletic population. All right, so I would like it to be a more interactive session wherein you can ask questions and I can answer them rather than keeping it more didactic. But if you all are confused in terms of what you all want to ask, I mean, you could ask anything from assessment point of view, anything that you have encountered in clinics that has bothered you and that you should. Maybe I could try and address that. So yeah, we could have it in a question answer form, though we could have a didactic lecture form, but I think that gets a little boring and it's a little passive and it's one way. So I would like to answer questions. So we can get started right away. If you all have any questions, let's start addressing them. Please feel free to add in any points or any tips that you all think I must have missed out or are relevant to the given topic. I would be very happy to learn myself. Okay, just because I'm fielding question doesn't mean that I have the answers to all the questions. So yeah, let's get started. You could type in, you could unmute yourself and ask the question. I think that'll be easier. Anything that you all want to know about overhead shoulder mobility. Also, I hope everyone's doing good in lockdown 4.0 in India. I think you could just unmute yourself and ask the questions.
Okay, maybe just to get people get things started, could you talk a little bit about how exactly you can assess overhead mobility, maybe the different tools, techniques, just simple assessment overview might be helpful.
Right, okay, great. So in terms of assessment of shoulder overhead mobility, what we need to understand is that we have very limited objective options, okay, because especially when it comes to the scapulothoracic joint, okay, we have the shoulder complex and each of them have different contributions in the different phase of the scapulohumeral rhythm to bring about the whole movement, the whole arc of movement. Okay, so there's scapulothoracic, there's AC joint, there's SC joint, and then you have the glenohumeral, obviously. So everybody has some or the other form of contribution. So of which obviously the glenohumeral and scapulothoracic contribution claim the highest amount of degrees to bring about the movement. Okay, so these two are the ones which actually are responsible for bringing about the full movement. So out of which, for glenohumeral, I think it's easy to quantify the motion. But with scapulothoracic, I feel it is a little difficult to quantify the motion. Could be because one portion of it is completely axial. Okay, so the thoracic portion of it, the articulation is axial. So I think that is one of the reasons why it's difficult to objectively measure scapulothoracic movement. So I think we must rely a lot on subjective examinations and our eye and our practice and probably palpation more on being able to understand. Again, there is no arbitrary normal that it has to be so and so degrees or it has to be in a certain position, etc. It could be different for different individuals, and that is something we need to respect. Could be certain position could be symptomatic for one individual, and it may not be for another individual. What we see, the findings, the anterior tilt, the upward rotation, the posterior tilt, abduction, protraction, etc. of the scapulothoracic joint, that is, they're all arbitrary motions, that it has to be within somewhere in that range. Okay? But it doesn't mean that if it is deviated from it, it's wrong or it's incorrect or it's dysfunction. Okay. So yeah, we could roughly divide the testing into three portions for our convenience. Obviously, static, dynamic, and functional are for any given assessment. They are always going to be the three subclasses. But I think here what we could subdivide it into would be tests in standing. Then we could have tests in supine, and then we could have tests in standing and supine that could be like some self-assessment measures. Okay, each of them will give you great idea about what exactly is wrong with structure, and you'll be able to essentially uh, localize your problem, which is what is really essential for you to go ahead with the treatment. Okay, which we can discuss, of course. So in terms of assessment, I would say the best way to assess overhead shoulder mobility is obviously by asking the patient to do an overhead movement. Okay, doesn't get any dumber. I mean, it's any easier than that. You have to ask the person to perform elevation. When I say elevation, it means always in the scapular plane. Flexion and abduction are over. Yes, we would ask them to do an elevation, which is going to be in the scapular plane, and then we're going to look at several points. So in pre-reading, the reading material that I provided earlier today, it it had Mike's video that it explained what all are the different components that we need to consider before before we start the assessment. So it has to be we need to consider the ripple effect of the kinetic change. We have to be considering things proximally as well as distally. So we have the glenohumeral joint, the scapulothoracic, the thoracic spine, and the lumbar spine. All these four things will have greatest amount of effect on the shoulder. I mean, yeah, like if you go with the kinetic chain and analogy, maybe stubbing your toe could affect shoulder, but maybe not immediately. What could have immediate effects would be your lumbar spine, thoracic spine, scapulothoracic joint, and of course the glenohumeral joint, which is the major portion of the shoulder complex. Okay, so we need to look at all of these four components before we start the movement. Okay, and before we start the assessment, that is. So I think the best thing to do is ask them to do an elevation, adequately expose the part, and notice what the movement is of the scapula, of the shoulder. So here are some really fantastic tips that we could just skip to the actual things that we are supposed to have an eye for when you're doing the elevation. Okay, so when you do the elevation, okay, like an overhead elevation, one must look at what is the distance in between the ear and the humerus, okay, or your arm. Okay, that will give you a good idea about what exactly is going wrong in terms of the abduction. Because various times what we ask the patient to do is that we need to go from point A to point B, okay, and they just do that because you've asked them to go from point A to point B. They feel like we think that if they've achieved point B, that means our assessment, the finding is normal, which is not necessary. We need to see whether they took the path of least resistance, which they most commonly will if they have any kind of deficits. Now, what are the kind of deficits we're looking at? Looking at capsular deficits, motor control deficits, muscular deficits, maybe neurological deficits. Okay, these are the four things that we would be looking at when we want to basically narrow down a finding. We need to find the culprit, and so I could show a few videos. I think they would be really helpful. But just to give you an overview, it's first thing you need to look at when they do the elevation. What is the distance in between the ear and the arm? So that will give you an idea when you do it bilaterally. You'll get to see if it is symmetrical or not. Second thing that we can look at the glenohumeral joint, this is at the glenohumeral joint that I'm talking. Second thing that we can look at could be if they're doing too much elbow flexion. Okay, so if they've done their elevation, if they've completed their elevation, but they are the elbow is slightly flexed, okay, this way. right? So this could give us a false, I would say, a false apparent picture where you could see that they've completed the elevation, but the compensation has actually occurred from the elbow because they lack abduction. All right. So they're just giving you an illusion of completion of the movement, but it's actually not complete. There's some compensation that's occurring without them understanding it. I'm not saying that a patient is going to scheme and plot and come in and just give you a false idea. That's never going to happen. Obviously, it's going to happen unknowingly. Okay. Next thing we could look at would be, of course, the obvious sign, shrugging of the shoulder. Is there shrugging of the shoulder once they do a shoulder elevation? And let me tell you, it's going to be extremely common with athletes because they love to do all sorts of weight training, like the deadlifts and whatnot. So in that case, because they've been doing lifting movements all day during their training, it's a lot of shoulder elevation, okay, a lot of shoulder shrugging, and you could also see hypertrophy, maybe upper trapezius levator, right? So that's very common, especially in athletes who do a lot of overhead work, snatch, or maybe like a press up or a pull up. They tend to use their elevators a lot, okay, which just shows that there is definite amount of some sort of deficits in the lower trapezius or your serratus anterior, that the upper trapezius has to take over that function. Okay, so that's the next thing we can look at. If they are doing too much shrugging, okay, which would mean that the levator and upper trapezius are overactive. The next thing we can look at obviously would be asking them to do the movement and see how much is the upward rotation of the scapula, okay, because that is the movement that is going to help you reach those last few degrees of elevation. Okay, that's really essential, right? So that's somewhere in the second phase of the scapulohumeral rhythm. So you're done with your setting phase, that's up to 30, around 30 degree, and then you come up to 160 degree is your actual scapulohumeral rhythm, where you're going to need upward rotation and posterior tilting and abduction. So there are ways we could see that. And one of the best ways, as I've mentioned even in an earlier webinar, is to see where is the position of the inferior angle of the scapula. So once you ask them to do the movement, if the inferior angle can be palpated straight along the seam line of your t-shirt, okay, the side seam, if you could see it there, then you can be sure that they've done good amount of upward rotation, good amount of protraction, okay, and so that would be the next thing you would want to see. So obviously you could divide your assessment, even planar assessment. So you could have maybe like a sagittal plane assessment, and you could have like a frontal plane assessment. So what I just told you, all of that was frontal plane, elevation, upward rotation, to see if the elbow is flexed or not, the distance in between the ear and the arm. All that is a frontal plane examination. Sagittal plane examination would simply give you an idea. You have to look at the quality and the quantity of the movement. So I think the sagittal plane would give you a great idea about any compensations in the sagittal plane, which could include inadequate extension at the thoracic spine. So they are going to make up for it by doing hyperextension at the lumbar spine and then still achieve the full movement. Or if they can't do, if they're so stuck in that position, they will not even be able to complete the movement on that particular side. Okay, so that is one way to do it. That is in standing. In lying, again, we're going to look at who is basically restricting the overhead mobility. Is the capsular portions, usually the inferior capsule, or it is latissimus dorsi or teres major. So again, the rule of thumb, if the scapula is jutting out when you do elevation, then you can be sure that it's teres major that is tight. If there is going to be excessive hyperextension, there could be two reasons for it. Either it could be a lat dorsi tightness, or it could be a poor motor control issue. I mean, it could be either way. Even if the scapula juts out, it could be a motor control issue actually. So those are two things that you can look at. And the moment you go into the thumbs down position, which is internal rotation, what you've done is you've relaxed the tight lats and teres major. So you get full movement once you internally rotate. Okay, so you're going to get full movement overhead. Again, you could be sure then in that case that either teres major or latissimus dorsi are restricting the movement. Okay, so that is something we can see in supine lying. And one of the best methods to do a self-assessment would be you could be in the crook lying position, that is your supine, with your knees bent, and you ask the athlete to perform the movement and just see if their thumb is touching the ground or not. If it's not, if they have to do compensations, then it's clear that there is some deficit in the overhead mobility. And I think one foolproof method of doing self-assessment could be against the wall. So you stand a few degrees away from the wall, such that your entire back is touching the wall, and then you just ask them to do the movement. Okay, so they're going to be fully touched to the wall, right? Their legs a little away from the wall, and then you ask them to do the movement, and you're going to notice if they can complete the movement or not. So I think those are positions which completely show if there are any deficits in the overhead mobility. I always feel that overhead elevation is to upper limb what a single leg squat is to your lower limb, because it's going to right there check your upper kinetic chain very easily. It's going to give you deficits very, very easily. So I think if there were a counterpart of a single leg squat in the upper limb, it would be the overhead elevation. So that's the assessment portion of it. Obviously, I would like to mention something which may not, which maybe a lot of us don't know, but we tend to look at, in our postural examination, we tend to look at a lot of static, I would say static findings. So especially your Kibler slide test, where you're just looking at, points from the spine and you're going to check the distance. I think these are all static assessments, and they've shown to be very poorly correlated with injury prediction. They are not really done alone. They don't predict injury as well if they were to be done with dynamic, with postural tests, with the relocation and the assistance tests. So I think just to say, if in the static position you notice winging, just to be very sure that it is, oh my God, it is, something neural, etc., etc. I think that is wrong. You should correlate it with the dynamic findings, which is what I just mentioned. So I think that even covers the thoracic and the lumbar spine. So obviously, when we perform the overhead elevation, there has to be extension at the thoracic spine, but not at the lumbar spine. We need thoracic spine extension for completion of the whole upward rotation of the scapula. But if it is the lumbar spine, then it's just going to indicate a poor lumbo-pelvic control firstly, or a motor control deficit, or maybe a dorsi hypomobility. Okay, so I think that is on assessment. Anything that I must have missed, or anybody wants to ask anything about this? All of you are awfully quiet today. Why is that? Is it because you come back after a very long break? Come on. Satyajit, I'm waiting for your questions. Come on. Is it good enough? Like, good enough to understand? Yes. Yes, always.
Oh, I'm just thinking about how this is like relevant for sports specific assessments. So someone like an overhead thrower versus someone like a golfer.
Yes.
How would you distinguish that? I mean, I'm just stimulating discussion here because we seem to
Yeah.
have
Yeah.
shy people in the group.
Yeah, it's a fantastic question. I mean, if you ask me, I would say obviously for a thrower, it's going to be more crucial as compared to a golfer. But of course, even the swing and the deceleration in a golf swing actually needs some level of overhead motion, obviously. But it's not, I think it's not past maybe 130 degrees or 120, 130 degrees. I think that's where it stops. So maybe that much amount of motion would be enough for a golfer. Maybe not for, say, a badminton player or say a baseball pitcher or even a cricketer for that matter, like a bowler. I think even a bowler versus batsman, I think it will be more important for a bowler to have that kind of overhead mobility as compared to uh, a batsman. Even in as I had mentioned already, with power sports, Olympic lifts, power lifters, they will not need, they will in fact need overhead mobility, because you have this, the clean and snatch, okay, which is essentially where the barbell is going to be above your head. So you're going to need movement for that. Also, now that you just pointed out a very interesting fact is when you compare, say, an overhead press is where you're supine and you have to lift the barbell, versus when you have to do a snatch. Though those movements apparently are overhead movements or above 90 degrees, but the plane of the movement is completely different. Okay, so in a snatch, you would need more upward rotation of the scapula as compared to an overhead press. If you just visualize the movement, an overhead press versus snatch. So I would say, if I am not too sure, there are two events. One is an Olympic lift, and then there is powerlifting. Uh, Powerlifting has snatching, and Olympic lift needs you to do the clean and powerlifting has the overhead press, and the Olympic lifts need you to do the clean and snatch. So again, for two different athletes, who are both power athletes, the relevance of shoulder elevation is it's completely different. The requirement is completely different. It won't be too different for, say, a tennis or a racket sports. They would equally both need it as much. But definitely, if you had the analogy of a golfer versus a thrower, for a thrower, it would be more career. I would say a career, not career ending, but career affecting pathology to have lack of overhead shoulder mobility. But even otherwise, I feel if it's an upper limb centric sport, your shoulder complex must be in a pristine condition, because compensations anywhere else, or maybe even overuse injuries, if we're not talking about acute traumas, they can be quite irritating later on. I hope that answers the question. Okay, what are the chief complaints that the athlete comes with specifically? Is it pain or just restriction or both? And how does that change? What the complication might be? Okay, let me read that again. Chief complaints. All right. Is it pain or just restriction? And okay. Is the question specific to a particular sport? Yeah. Yeah. So, Satyajit, I mean, if I had to answer that question, athletes will normally come with both. They'll come with stiffness also and with pain. Okay, they'll come with any sport. Let me give you an example of a bowler I treated. Okay, he had this particular complaint. He had stiffness and pinch in overhead, like in his during his bowling. I would say during his leg cocking, around that phase. Okay, so towards the end phase, when he's just at the most highest point of his throw, that's when he had a lot of pinch and irritation. Okay, so a pinch and irritation would alarm me more. Okay, because that tells me now there's not just stiffness, but it has begun to irritate structures in the area. So that will alarm me more. Not that I will not pay attention if the patient is or the athlete is coming only with stiffness. Obviously, even with stiffness, that is equally important, because then later on they will develop pain and pinch. But there's pain, pinch, and stiffness. Obviously, I'll prioritize that more. So if I had to answer, if they're coming with stiffness, it just could be a precursor of what they will come with pain and stiffness. You get my point? So it could be like a pre-stage of an impingement, or it could be like a pre-stage of yeah. I mean, mostly what we see in them is it could be an impingement, internal or external impingement, or it could be a pre-stage of a tendonitis or a pre-stage of some kind of rotator cuff irritation. It could be pre of that, okay, or it just could be capsular. You could narrow the structures variedly in it, like depending. Then you could just use your special tests then and then try and find. Okay, but I wouldn't completely swear by a special test. I would rely more on my subjective objective findings. Okay, so when you go with the SOAP format, the subjective and objective come before assessment. The assessment is nothing but your outcome measure, your special tests, and your scales. So I think subjective and objective is going to set the stage pretty much, and then you can go ahead with your assessment, and then planning is nothing but your treatment. Okay, so does that answer your question? Great. Yeah. So that's how it is. But obviously, you need to pay equal attention to both. Equal. Could you speak about strengthening in a hypermobile athlete? Okay. Okay. All right. In a hypermobile, that is instability. You're talking about instability, is it, Hannah? Are we talking about dislocation, recurrent dislocations? Yeah. Okay. Okay. So this could be a whole another webinar, I think. But in with dislocations, I think because there is so much disruption in like the intra-articular structures suffer so much with a repeated dislocation, especially recurrent dislocation, that I think obviously strengthening and everything plays an important role, no doubt. But I think motor control and neuromuscular control and using your rhythmic stabilization and PNF, all those things become very, very important because they've lost the hang of how to control the joint. I mean, like that. I mean, I wouldn't say in a subconscious control, but that innate control that exists in the joint. They've lost the habit of it. So I feel no amount of plastering on the outside and just trying to bulletproof your shoulder from the outside is going to benefit them if done alone. It has to be with the motor control, aspects of it. Again, I would encourage you to follow a triage of treatment, or very sequential. We all love to jump to strengthening right away when we see an unstable shoulder. We all love to jump to neuromuscular training when it comes to any I would say any condition. But I think we should follow a triage where obviously one point can get less attention. So it's again, as I don't know if you attended my lumbopelvic the lumbopelvic discussion, where I had mentioned that we need to inhibit, align, mobilize, strengthen, and stabilize. Okay, it's going to follow the same sequence. To inhibit the muscles that are overactive. In this case, levator, upper traps, rhomboids, all your tight muscles showing trigger points. Those are your overactive muscles. You would like to inhibit them. You can be very creative with whatever you want to use to inhibit them. So it could be anywhere from breathing control, relaxation, to soft tissue mobilization, you like. Okay, you can be creative, innovate in those criteria. And alignment would mean your mobilizations. Again, now you would be surprised that I'm asking you to mobilize already hypermobile shoulder. So maybe alignment could mean something else in a hypermobile, in context of a hypermobile shoulder. Okay, maybe you could just do some drills where you could teach them how to center the humerus in inside the glenoid, and that would be doing some co-contractions, rotator cuff, deltoid, maybe some isometric, something like that. Okay, so you could do that in terms of activation and aligning. Mobilizing, I would not encourage you to do mobilization in an already hypermobile shoulder. Then you can go on strengthening and stabilizing. Strengthening, obviously, you have to pay attention on the scapula. You have to pay attention on the core as well. And of course, you have to pay attention to the rotator cuff. Has to be, I mean, there's no getting around that. That rule of thumb will not change. You have to concentrate on the rotator cuff deltoid couple by strengthening the rotator cuff, because it has that downward resultant force that helps in centering the humerus onto the glenoid. And of course, then you must remember that when you see instability, that most of the burden is now going to be with the dynamic stabilizers, because your static stabilizers have somehow failed at doing their job, okay, or they are just too excited to do their job rather in this case. So I think that's where you would be focusing a lot on dynamic stability, and that's not going to change, of course. And then neuromuscular control is going to be a lot about rhythmic stabilizations, as I said, which is nothing but you are in this certain position and you're going to do resisted isometric in different planes. Okay, that could be one thing, or you could do your PNF patterns. One nice way to do it would be in the half kneeling position. You could be in the half kneeling position and ask them to do different patterns, maybe the D1 pattern, if not the D2 pattern, because it's going to take you in abduction and external rotation in the initial phases, obviously. I'm talking very general, Hannah. I'm talking extremely general with respect to any type of instability. Now we need to see how that instability is being managed. Is it an operative management, or you getting a chance to conservatively manage them and then maybe see the outcome and how it is, whether it is a traumatic instability, whether it is a recurrent instability, whether there's dislocation that they've had, and if there are concomitant tears with it, you need to factor all of that in. But I think if you had to have some general principles, this is how it would look. You would want to inhibit the overactive muscles. You would like to get good alignment of the joint. You can skip the mobilization part. You can go on with strengthening the dynamic stabilizers, which I just mentioned. And then you can go for the stabilization, which is also going to have your sport specific movements, maybe your throwing program, interval throwing program, doing overhead motion, virtual reality, and all those gimmicks. You could bring in all of that. But once you have this, I would say this outline, you can innovate inside as much as you want. Okay, so yeah, I would also uh, add a few resources. Yeah, thank you. You're welcome. I would add a few resources in the end where I know, at least for rotator cuff rehabilitation. Okay, it's not really. I mean, I wouldn't call them protocols. I would call them more of principles, because a protocol, I feel, just limits you, considering that every patient is the same and all size. I mean, one size fits all kinds. With principles, I think there is room to innovate a little more. Yeah, okay. Anna, is that good enough? Yeah, great. Okay. Anything else? I purposely planted a few people in the audience to ask me questions. What are you guys doing? Come on. Just ask a little difficult one, so that I don't answer. Just embarrass myself a little. Just feel existential and maybe go back and read or something like that. Yes.
Yeah, I'm gonna
Anything?
be devil's advocate here. I'm gonna ask a question. What are the
Yeah.
most reliable and valid special tests of the shoulder that we know of currently? What's the current evidence?
I'm sorry. What is that again?
What is the current evidence for the reliability and validity of shoulder special tests? Are there some which are better than the others?
I mean, if you had to compare shoulder and knee, okay, if you see the number of tests there are for shoulder, the sheer number is so much. Like, I think there are about 60, anywhere between 60 to 100 special tests for every structure in the shoulder joint. There's a select few in the knee where you have Lachman's, anterior draw, and your pivot shift, and magma raise, and you're done, and that's it. Like, for every structure there are maybe 2 or 3, out of which one is proven to be fantastic for that given ligament, etc. But with shoulder it's not like that. And if I had to see the fact that there are so many tests, it goes on to show that they may not be reliable right away. I mean, if you had to just get to a finding on the basis of a special test, they're not. They're not valid or reliable. I mean, that's what it was like until, I would say, till 2016-17. So there isn't any new. I would there maybe clusters of tests, they're good rather than going for a single test. So clusters conclude better in a shoulder joint, I mean in the shoulder joint as compared to the knee joint, and not any single test. And I think that is the reason why there are so many tests, because they can all be done in clusters. So the individual number increases. So I would say them done in clusters. They're good. I mean, they're good predictors, but not really. Is that good enough, Ways? I don't have numbers, unfortunately. Of even some of them even lack sensitivity, actually. So that is why, as I said, there are so many of them for the shoulder joint. But yeah, the SAT, SRT, etc. for the scapula, they're good, valid and reliable both. Good predictors of injury, and but as I said, they have to be done with the static dynamic and uh, the postural tests, like the functional tests. So that is really important.
Vaishnavi,
Yep.
if you have one scapula which is lower in level than the other one, like if you're checking the inferior angle and you find one side lower, which muscles do you think are underactive and which ones are overactive?
Yeah. So when you have, and this is a very common finding, especially in unilateral sports, like in the throwers. Okay, so
Yeah.
yeah. So if you had to ask me if there is a lowered scapula, there is definitely some disturbance with the serratus anterior lower trapezius couple, as well as the upper lower trapezius couple. So I would say the rhomboids would be overactive with excessively depressed scapula. And I think a depressed scapula would also inadequately upwardly rotate. So serratus anterior and lower trapezius, they would both be inactive.
Okay, no, because I have like this one case. So his range is full. There's no
Mm-hmm.
pain, nothing. Just the sensation or the appreciation of one side being lower than the other. It does not
Mm-hmm.
bother him as such, but that discomfort is continuously there. And the
Uh,
rhomboids don't seem
discomfort about
overactive.
like a discomfort as in pain, or the feeling that it is lower than the other way.
A feeling that it is low. No pain. Pain was there earlier. Now there is no pain or
Okay.
anything of that sort, but the feeling of one side being lower.
So I think that could be something more subjective, maybe something neuromuscular, maybe some motor control, or maybe some proprioceptive component to it, maybe instability, could be anything of that sorts as well. If you're saying he's feeling it and it's not giving him pain, there could be some neurological, perhaps, a component to it. Or maybe, yeah, because at rest, you're not even saying during movement, right? Like he's feeling one is lower than the other.
present at
At
rest,
rest,
and it's almost like a good 2 fingers down compared to the other side. So I initially thought that the pec minor and the lat, which will pull it down. So I released that.
okay.
Now it's come to like half to 1 finger, like in between that, and I can't figure out the remaining part of it.
Then I think it could be perhaps a motor control. That would be my guess, because if you've released all the soft tissue and then you still find the difference, it could be that. And it could be, is there any winging
There was not
dynamically?
anymore. Not anymore.
Yeah. Yeah. So again, winging is pointing at something neurological, I feel.
There
So
was
I think it
winging
would be
earlier
good to test.
because of a weak serratus, but that's no more present.
Yeah. Okay. Okay.
So
So
my guess is like a weak
maybe an
trapezius and levator scap, but upper trapezius, but like upper trapezius being weak is a little
yeah, no,
unusual.
no, that won't happen. Yeah, but I
Yeah.
think your guess with lat dorsey was good enough. That could be definitely one of the culprits, because you're saying if you release and it has improved, so that was definitely contributing to it. I think there could
Yeah.
be some lower trapezius deficit as well. So you could do that.
Yeah,
And
probably. Yeah.
no, and levator and upper traps won't be weak unless, again, if it's neurological. If it's a spinal accessory nerve issue, then why not? You would have an upper trapezius and a levator scapulae weakness as well. So that's why I'm saying it could be a neurological, a motor control issue, or maybe a lower trapezius insufficiency.
Yeah.
Yeah.
Okay, thanks.
Yeah, you're welcome. Thank you. Thank you for asking me a tough question, Payal.
I'm finding it really difficult to solve this one case, so I thought I'll ask you. Probably you would.
Yeah, I mean, you could maybe use some and let me know how it goes.
Yeah. So initially, like
Thank you.
there was also like an upslip on the opposite pelvic bone. So, but after releasing the lats, not exact, you can't exactly say an upslip as such, but the lats pulling it slightly up. But now that's also like resolved once we release the lats.
See the fact that again there is lumbopelvic issue. It's giving me a very motor control-ish culprit behavior. Like, I think it
Yeah,
could be that. I mean,
probably.
if you do some, maybe, yeah, you could maybe teach him some bracing, and if you, as I said, if you do it in that half kneel position, if you do some PNF activities, I think it could really help with that. I mean, the at least the feeling of that one is lower than the other would go away with maybe a mirror in the front. So you posteriorly tilted the pelvis, you've braced and given a strong base with the lumbopelvic complex in place. Then you could go up, go for PNF or D2 flexion, so that will give you good amount of thoracic extension. And since a D2 flexion is nothing but a Y exercise, so you're getting a good lower trapezius activation. Maybe you could try that.
Yeah, makes sense. I'll try that.
Yeah. Like what sport does?
Basketball.
There you go. Yeah, I think it really benefit. Overhead. This is a nice question. I mean, basketball is one of. I mean, we don't address a lot of basketball in overhead sports. I feel because basketball has a lot of ankle attendance given. So yeah, thanks.
Issues. Yeah, yeah.
Yeah,
Thank you so much.
no problem. Yes. Anybody else? This is going better than I expected it to. Do we have thoughts on scapular dyskinesia relevant in athletes? Relevance in athletes, is that what you mean, Satyajit? Scapular dyskinesia? Thoughts as in, like, what would you like me to express my thoughts on, if I had to ask? I mean, is it relevant? Of course it is relevant. Of course. But see, I mean, what's not relevant is to set the standard that you have not upwardly rotated 60, 40, anywhere between 45 to 60 degrees, and you're at 44 degrees or 58 degrees and you have scapular dyskinesia. That's not good. That's if in the beginning I said, these are just arbitrary figures and we all probably fall in that range, and maybe normal for one may not be normal for the other. Of course, but dyskinesis, but if it is completely going out haywire out of that, I would say that limit, then definitely dyskinesia is something that you need to consider. 1 or 2 degrees here and there, maybe not. Even if it doesn't hamper the athlete's play. Yeah, good that you asked me. Now, if I would want to know, now if you're asking me if it doesn't affect the athlete, if the athlete has played all these years without an injury, if they are in a particular sport with scapular dyskinesia, that's very unlikely. I can guarantee you, if there's scapular dyskinesia and they've played for so many amount of years, they are bound to have some or the other form of, problems. If you're saying a new athlete and they don't have symptoms, they may develop symptoms later. So if you picked up scapular dyskinesia, then I think it's good to, I'm saying overt scapular dyskinesia. And and also now that you brought the point, I think the commonest forms of dyskinesis that we usually see would be reduced control or reduced downward rotation. Okay, so eccentric control could be poor. That's one definite type of altered movement pattern that you can see. Second is a winging. Okay, it could be either medial winging or lateral winging, and a shrug, each of which I covered during the assessment portion, if you remember. So it could be a shrug, it could be winging, and it could be excess downward rotation or lowering, which is what Payal just asked me. Excessive downward rotation during lowering. Okay, if there is excessive downward rotation or lowering, then it tells me definitely there is some sort of wrong, I would say, there's some sort of an issue with and trapezius. They are essentially lowering the scapula. A shrug would tell me if there is any levator or upper trapezius overactivity. Winging, usually, if it is, usually is neurological, so it would give me a serratus anterior insufficiency again. Okay, but so these are the altered patterns that you're going to observe, and if you see them, they won't be asymptomatic for long. I mean, if you've seen it and you think that they are moving in a wrong way, then I think it's always wise to correct it. What I mean, I don't think a dyskinesis has to be symptomatic for it to be called dyskinesis. You get what I mean? Like, unless it's resulting in pain, it's not dyskinesis. I would differ. Like, even if there are studies saying that if dyskinesis is not painful or it's not symptomatic, that it's not dyskinesis. I would say pain or irritation is not the only symptom that we come across. Okay, the way you move, your performance, the feeling. Now, as Payal just gave an example to us, that the athlete is not feeling all right. If they're not feeling all right, they will not move all right, and they will not perform all right. So it's all about feeling, moving, and performing better. Yeah. So I would say, some evidence says that dyskinesia, reduction in some movements in excess, is just an adaptation, is just an adaptation to the sport rather than an issue due to the sport. Yeah, as I said, yeah, like it could be an adaptation, but I don't think if it's an adaptation, there would be asymmetries more than dyskinesis. As I said, for you to call it, it depends upon the definition of the dyskinesis. Now, I would want to know how have these people defined a dyskinesis, right? If they are saying that it's an adaptation, so I would want to know what was their definition of dyskinesis. Yeah, sure, Payal. Yes, please. Yes, please.
I guess GIRD is not like an adaptation to the sport. It's more of because in overhead players there's so much anterior translation of the humeral head with every time the hand goes up. The anterior part of the capsule gets overstretched and the posterior capsule gets tightened as in compensatory mechanism. So because of which you have like anterior translation and superior translation of the humeral head, which causes GIRD. So it is correctable and it can be problematic later on because this position of the humerus is also going to make it more susceptible to impingement. So I don't think scapular dyskinesias take place as an adaptation to a sport.
Yeah, exactly. Yes. So if we the position of the humerus is obviously going to affect the glenoid in this case. So I think it will be more anteriorly tilted, isn't it? With reduced upward rotation and reduced abduction.
Yeah.
Yeah. So it's all interlinked. So even if we are calling it an adaptation at the asymptomatic stage, it will later definitely bother. And uh, as I said, it won't necessarily present as a shoulder problem. Again, are they asymptomatic in general or are they asymptomatic only at the shoulder? Okay, let me see. A right-handed tennis player would see different scapular movements and position in his right scapula as compared to left. That's correct. That's right. That's what I said. That's asymmetry. That's asymmetry because he's using his right. I think it could be even for us, like even for us, our right and our left, or for the lefties, the left. So that's asymmetry. Okay, and that cannot that cannot be equalized to dyskinesis directly. So as I said, dyskinesis would fall into those three things that I just mentioned: either winging, shrugging, or I would say like reduced control during the downward rotation. In fact, some of these adaptations, what Payal just mentioned, the girl and the girl that you get with the girl, that extra few degrees of external rotation in that phase help the athletes with their performance. I mean, the fact that they have developed it is because they get good amount of help with it. Yeah, it helps them, that girl and girl. But as I said, it would, in the long run, it definitely would affect. I would also say that they had, if they have to rely on a GERB for enhancing their performance, are there any deficits elsewhere that is causing that GERD? So can I still get good performance without a GERD or without a GERD? That is what I'll ask myself. Like, why would I disturb a normal, like biomechanical movement? A normal as in arbitrarily normal biomechanical movement to get performance when I can do that if I optimize the kinetic chain. If you understand what I mean. Satish, you can unmute yourself and ask, maybe that will be better if that doesn't answer a question yet. But it's a great question. No mic, okay. Does it, like, Anything else you would like? That's what I think. I mean, that's my way to look at it. I feel that if there's any way I could get the same performance without a girl, then why not? But if the adaptation has already taken place, then is there any way I can still make sure that they perform well and not land up with an impingement, which they will? And that's what I'll just explain that how, isn't it? That will eventually happen. That is why usually in non-contact sports, we see a lot of overuse injuries, uh, more than acute traumas. This is the reason why, because we wait until they become symptomatic. We wait until they are able to perform well in that given whatever adaptations that they do. I mean, if a girl or a girl were to not like they were to benefit an athlete, I don't think we would have seen so many impingements or so many internal, external impingements, or issues like that. Would the body have adapted to the different stresses that the player goes through in his tennis career? So the GERD and GERG are due to tennis and a way for the body to adapt to tennis. There is a I do not exactly remember. If somebody could help me with this, there is a cutoff point. Okay, even if you're saying GERD GERG, there is a certain ratio cutoff point. I think Saloni could help me with this. A project was on GERD and GERG. There is this cutoff beyond which it is strongly correlating with impingement. Until then, it's fine. Beyond that, it can cause a problem. Could you help me with the number, Saloni? Are you there? Is it more than 1? Something like that. If the ratio is more than 1, then it is considered dangerous for the athlete. As in dangerous, as in it could be injurious. Yeah, right. Yes. So yes. So if you're seeing adaptations to a certain extent are good. Like maybe up to that ratio. It would be good enough to find the exact number. So if that GERD-GERG ratio is within that ratio range, then it's fine. But beyond that, it's strongly correlated with impingement. If you get what I mean. Is that good enough, Satyajit? Also, how do they differentiate between asymmetry and dyskinesis? If the patient is asymptomatic, pain-free, and has no debilitating effects on his play. Yeah. So this is where it gets a little nice. That's a good question. I think this is where it gets very tricky because a lot of it is subjective examination. That's what I mentioned earlier. Isn't that's uh, that is, it's very difficult to set a cutoff point that beyond so much. No worries. Thank you, Hannah. Thank you. Uh, uh, I think the issue with this is that we have to rely a lot on subjective examination, and these cutoffs go on varying from athlete to athlete. Okay, unless you see something overt, obviously, then you can safely conclude that the patient or the athlete has dyskinesis. Okay, but there aren't numbers that suggest that okay, if you're so and so degrees less, then this is dyskinesis, or then if you have so and so degrees, then you are asymmetric. That is why if you know Ben Kibler's the scapular slide test that you do, the whole type 1, type 2, type, all different types of scapular dyskinesis, the classification, they became redundant because it was putting numbers and trying to limit the pathology in some way, when it is not like that. It's extremely subjective. So I think one of the researchers was Tim Yule, I think. He just he just reduced it to a yes-no kind of a pattern. Yes, they have winging. Yes, they have elevation. Yes, they have reduced downward rotation. Or no, they don't have any of this. He just completely made it really broad, yes, no. And for you to say yes with conviction that they have dyskinesis, you should overtly be seen. And if you're overtly seen, there are high chances that it will cause symptoms or that it has already caused symptoms to the patient. But if you're saying if the patient is not symptomatic and they have these overt movements, I would not rule out a dyskinesis. If that's what you want to ask, does a dyskinesis have to be symptomatic for me to call it dyskinesis? I don't think so. Is that good enough, Satyajit? Does that answer your question? Are there any good research articles I can read regarding this? Yes, you can. I would lead you to. I'll send you some of them. I'll send you some of them. Most of this is actually my clinical, I would say, opinion. Most of it. I'm relying on what I've seen in the clinics to answer this question. But of course, I can definitely help you with some articles. You can actually read a lot of Ben Kibler's work. He's actually the person who's coined the term scapular dyskinesia. Aaron Shaya, he's worked with Ben Kibler in Kentucky. He's somebody fantastic to refer stuff to. Mike, James Andrews, these people have done a lot of work on shoulder and scapula. So I'm sure they have answers to these questions. Yeah, I'll write. Yeah, you're welcome. I'll leave the names in the chat later. Yes. Anything else? We're going good. Lasted an hour. I'm happy. I thought it'll be like a rip-off. Oh, sorry. Yeah, Anushi, what I want you to, what I want to know is that you want me to tell you beyond what is considered significant, good, or you want me to tell you in which kind of athletes do we see it? Or you want me to tell you about the assessment portion? You can unmute yourself and just ask me. Yes, both, but not assess. Yes, both, but not assessment. Okay. Yeah, so assessment is fairly simple. You just have to do the internal rotation, you find with the goniometer, and then you just basically find the ratio. But yeah, you would see that in the throwing athletes, racket sports, okay? Especially bowlers, cricket bowlers, and baseball pitchers. I think these are two definite people you're going to find good work. Even swimmers, for that matter, because they need to really embrace the whole range of the shoulder movement. So you would find a good work in swimmers, also in racket players, as I said, in tennis players especially. Okay, less of badminton players. I think it's because the gear is a little lighter as compared to tennis, but that's just what I think. But yeah, so you see it in tennis players, you could see it in swimmers, you could see it in throwers in general. Any overhead sports, basically. Though swimming is not counted as an overhead sport, but most overhead sports you're going to see that they have the Gertberg, yeah, internal rotation deficits and the external rotation, right? Assessment is pretty easy, and about the symptoms we already discussed that when after what point we considered it to be strongly correlated with injury. So I believe if the ratio is more than one, the GERD is to GERG ratio, if it is more than one, then it is strongly correlating with injury. That means if you have more deficit, and yeah, GIRD is to GERG. That's how I'm messing up the mathematical calculation. You could head to orthopedic physical assessment, David J. Maggie. It has the exact number and have to do the calculation. So if it is more than that particular number, it correlates strongly with injury. Does that answer your question, Anushri?
Hello?
Yes. Satyajit?
Wait, can you hear me?
Yes, I can.
I didn't know this had a mic, sorry.
Sorry, what is that?
I didn't know these earphones had a mic. The first time I found out in last 2 years.
Good. So this webinar has helped you in more than one ways.
Yeah.
Tell me. Or you're just testing the mic, is it?
Yeah, I'll ask you if I come up with any more questions.
Sure. All right. Anybody else wants to ask me anything? We're going good with this. I'm happy. Thank you for asking all these questions. Yeah. Shreya has a question, I think. No, Shreya is still on. You can ask me stuff. Okay. Yeah. Anybody else wants to know anything else? Wants to ask anything else? I think we've touched assessment, we've touched treatment, we've touched how it can be used in different athletes. We covered like sort of a clinical case. We tried to understand asymmetry versus dyskinesia, symptomatic versus asymptomatic dyskinesia, whether to treat it or not, and some self-assessment techniques. I think it was pretty good, pretty comprehensive. If there's anything, we also covered instability in short and the triage treatment. I'll leave everything. I'll leave notes for it in, I think Oasis has that drive facility where I'll leave a few of my own notes. Maybe then those will be helpful with some resources. I think that will be very helpful for those of you who want to do further reading. Yeah, anything else anybody wants to know, anywhere you feel that you differ an opinion with what I have said, you don't necessarily have to agree with it.
So I have one question.
Yes.
What are your views on? So we've talked about shoulder impingement, yeah.
Okay.
So sort of conflicting evidence even about shoulder impingement, which is shown that. So when we think about impingement, we think that the superior surface of the rotator cuff usually gets impinged in between the
The subacromial space, yeah.
acromial space. But apparently some research has shown that it's not the superior aspect, it's actually the inferior aspect of the rotator cuff muscles which actually show more degradation. And the, what do you say, the reason that
Yeah.
could happen was because when you activate, when you use those muscles, basically the muscle wraps around the bone, so wraps around the humerus. So when you keep doing that, basically the inferior surface is going to get
Great.
more affected.
Yeah. Yes, 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 yes. That's right. That's fantastic. That's a great question. That's called internal impingement. Okay. So you could have see, I mean, when we consider impingement, it's either external or internal impingement. So that's with respect to whether it is what you just described was intra-articular internal impingement. Okay, so that's your under surface of the rotator cuff and the glenoid rim rubbing against each other, okay, causing the fraying of your of the rotator cuff. Okay, so your entire assessment and your treatment is going to completely be different as compared to external impingement, because the very so with what you just described with internal impingement, the site of pain is going to be more posterior superior aspect of the scapula. Okay, versus if you have external impingement, there would be more anterior pain. Okay, so the localization of symptoms would be more anteriorly. And the two best ways to find out if it's an external or internal impingement would be to first see what the location of the pain is. So if it is posterior superior, then you can be almost sure that it is that it's internal impingement. And the next is to perform a special test actually, which is almost confirmatory, where you do like your anterior apprehension. So you're just going to lift your humerus in the scapular plane little in supine line, and you perform an external rotation in 90 degrees of abduction. You perform external rotation, and that reproduces the symptoms. All right. So then that is where you can find if it is your external or your internal. So yeah, it's extremely common in throwers, internal impingement, extremely common in throwers. Treatment wise, again you have to see what the impairments are, and again follow the same triage: inhibit, align, mobilize, stabilize, strengthen and stabilize. And you would be focusing a little more on the posterior cuff with internal impingement. You would be focusing, obviously, then your focus would not be much on widening the subacromial space, because that's not where the problem is. Doesn't mean that you will obviously that you will skip dynamic stabilization of the scapula, no doubt. I mean, because probably the scapula was not moving rightly, it led to that thing in the first place. So obviously you need to correct that, there's no doubt about it. But your focus will not be on widening the subacromial space or causing posterior tilt, etc. So maybe your SAT may not exactly give you the same result, or SRT or SAT. They may not be necessarily positive. Just because they are not positive doesn't mean there's no impingement. So as I said, the best way to confirm internal impingement would be with looking at the site of the symptoms, and the second would be with finding with the anterior apprehension, like the internal impingement special test. If any one of those are positive, then you can safely say that it's internal and not external impingement, and you'll focus more on posterior cuff strengthening in that case. That's going to be your teres minor.
So the thing I mentioned right now, we say that's internal impingement, right?
Correct.
And
Yes.
external impingement, I guess by what we've studied is due
Yep.
to the shape. So we studied the three types of acromions: there's flat, curved, and hooked. And because of the acromion, any impingement due to that could lead to external. But
Yep.
there's also evidence that says that the type of acromion didn't really have any correlation with impingement. in patients basically who had pain, who had subacromial pain. And also, there's another paper which I saw which basically compared a decompression surgery as opposed to a sham surgery, and they both had equal results. So, a decompression surgery didn't have the same outcome as either a sham surgery or no surgery at all.
That's because it could be an internal impingement. As I said, in that case, decompression would not really give you any result because you're not going at the point of issue.
Is that still impingement? We're not impinging. The muscle isn't impinging here. It's just it's tightly, I guess, grasping the bone. So the inferior surface of the muscle is
still impingement because even if the subacromial space is not compromised, that space, that intra-articular space is. Therefore, it is still impingement. It will still be called impingement. And the other what was the first few things that you told me before the decompression?
The type of acromion, the type of
acromion. Yes.
Yeah.
Okay.
And the correlation of the shape of acromion to the impingement or to pain, basically.
Okay. Yeah. So that is doesn't surprise me because that's what is primary. That's how we differentiate as primary and secondary impingement. Primary is where you have bony dysplasias and then they cause subacromial space alteration.
Right.
And secondary is if there is poor muscle timing or tendinitis or anything like that. No, not even tendinitis. Poor muscle timing, poor stabilization, etc. That or neurological deficits that would result. So, was this like what kind of a study was this? Was it like an observational study or how? And was it in athletes?
I have to go back and check, but it's there in the study, the link that OA sent on the group, study material basically. So,
Sure.
So he shared my...
I'll go through it.
Yeah.
Yeah, that's
I haven't read it either. I haven't read it properly as well, so even I need to go back and do that.
Yes.
Ones. But they're all there for everyone to see.
Yeah. So I think, like where you said, where the decompression surgery didn't work, it didn't work because it was not probably addressing internal impingement. But just because the decompression surgery didn't work, we cannot rule out the fact that there could have been internal impingement. It's still considered internal impingement. I mean, that's...
I'm not sure about whether it didn't work or not. I feel that it worked while at the same time the sham surgery worked as well. So that's the thing.
Okay.
So maybe the decompression surgery worked, but the sham surgery also worked. So
could be that. Could be that. Would be interesting to read the paper.
Just to interject and since we're talking about research there, I think an important point to keep in mind is when you're reading primary research, which is what Satyajit is describing, where you've actually it's a single study. It may be a randomized control trial or it can be a case study. Doesn't matter what it is. The important thing to keep in mind is sample selection. How was the sample selected? What are the characteristics? And how they've defined that terms, like Vaishnavi put it. It's it can be a little challenging to translate those findings into the clinical population that you see because of various factors, which is why we say that evidence-based medicine isn't just about reading clinical research and just applying it blindly. It also has to do with individual factors in the environment. So while it's important to look at these clinical studies, it's more important to keep in mind that one study does not constitute evidence. It's more important to look at systematic reviews, look at meta-analysis. And even in those, you have to see how they've selected their studies, what are how they've defined their terms.
Right.
Yeah, because in systematic reviews or a meta-analysis, there are very high chances of choosing different populations which might dilute the data and might give you a false impression. So it matters what is the range of the age and the population and that they've chosen, because if you choose a wide range of suppose age, then it could have anywhere from old people to really young athletes. So if we're trying to use the same information for our younger athletes, then maybe because we could have some false uh, interpretations from it, because it has some dilution with the older population in it. If you get what I mean.
That's
Is that right?
the type of sample should be looked at. That's very important.
Type of sample should be homogeneous, if I'm not wrong. Is that how it should be?
I don't think we'll ever get like a truly homogeneous sample ever, but
Yeah.
it's a good principle to keep in mind. Maybe we can talk more about understanding research maybe later on in like a separate.
Yeah. Yes, absolutely. Yes. Any more questions? Do we have any more questions? Was this helpful? Like, I think we've covered a wide range of topics, and we just didn't restrict. I mean, we could talk alone on shoulder overhead mobility for a while, and I'm very happy about that. I was hoping that it would end in like half an hour, but we had a lot of nice questions, so we could actually focus more on shoulder overhead mobility. I was going to basically, I was going to keep the webinar open, and then maybe after a point of time I was going to answer all other shoulder related queries, which we also did. But I think we could speak substantially to a greater extent on shoulder overhead mobility, and I have also understood. And yes, Satyajit realized his mic, his earphones have a mic, so I don't think there could have been any better day that today.